Hi again, everyone, and welcome to the premolars. When we're looking at extracting premolars, we generally look at that fourth premolar, which many of you have been taught to extract in wet labs. But we don't really pay a lot of attention to that in labs in respect to the other premolars. So let's take a look at some of the things that can happen and some of the radiographic changes in premolars that we find commonly and have to deal with on a fairly consistent basis. We talked about the first premolar in the dog, in the maxilla and mandible, and simple extractions, so we won't touch on that other than to say that sometimes we have very close approximations with other teeth with that small tooth, especially in brachycephalic dogs. And sometimes, in order to extract the adjacent teeth, we have to sacrifice that tooth. So that's not a problem. You can certainly do that. That can be extracted if it is too close in order to gain access to the bone adjacent to the teeth that you're extracting to that first premolar. Take a look at this radiograph. You'll see that you've got a pretty nice periodontal ligament space around these premolars, and consequently we can section these and extract them as simple extractions sometimes. And depending on what radiographic changes show, they can be very easy. This is the mandible of a young dog, and you can see there's a very large pulp cavity here indicating the dog is young. And then look at the periodontal ligament space around these teeth. It's very large, making it a much easier extraction than even the previous x-ray of a young adult dog. If indeed you have changes that suggest radiographically that you have ankylosis or other problems like tooth resorption, we see here where we've got a tremendous amount of destruction of the crown, you might need to do a flat-based extraction for those maxillary premolars. Mandibular premolars are a little bit tougher in dogs that aren't, as we just saw, they're young, that have larger periodontal ligament spaces. They can be a little bit difficult just because the cortical bone is so thick. So if you combine that aspect in the mandible, and you have in the mandible a premolar that has resorption that resembles this, where you've got breakdown of the crown, you've got external resorption due to inflammation. This tooth was fractured, and consequently, over time, the inflammatory processes started to cause resorption of these roots. So if you have that in the mandible, you definitely want to at least an envelope-based extraction to gain access to the roots. And all of those are going to be, all of the premolars extracted exactly the same way as the demonstration tooth that we're going to do, and that's the fourth premolar of the maxilla. So here's an example of one of those teeth in the mandible that would be very difficult to extract. If you'll note here, we've got an obliteration of periodontal ligament space, and we've got internal resorption here, we've got external resorption here. The bone actually has been maintained from the previous extraction site. However, the crown is starting to break down. And when you start to see the crown break down very shortly, it loses its consistency, and eventually you will have gingival tissue that is exposed adjacent to that crown tissue that's been destroyed, the root or the enamel on that crown, and you'll get influx of gingival tissue, and that becomes painful. So in this particular tooth, you would want to do a flap to expose this area. You probably want at least one releasing incision. I tend to go mesial on releasing incisions just to maintain the blood supply, which comes in caudally for the most part, and flap that over this way with your periosteal elevator, and then gain access to this and be able to take a lot of that bone off of these roots, sometimes even down to almost the apex, avoiding the mandibular canal, obviously.